This is the HBI 365 Big Picture Ophthalmology panel. Some housekeeping before we start. There is a Q&A function. If you look at the bottom of your screen, there should be an icon that you can tick. Feel free to use that, ask any questions that you would like the panel to address, and I will try to put as many questions as I can to them at an appropriate moment. Now, obviously we can't avoid talking about COVID, at least initially. A year ago today, as it happens, January the 27th, 2020, the World Health Organization began tracking COVID in Europe. The first European cases began to emerge, and by early March, a pandemic had been declared. Faced with travel restrictions, lockdowns, depleting resources, operators feared the worst. But while those businesses did feel a significant impact, generally, the bounce back proved to be perhaps surprisingly successful, with pent-up demand allowing significant, if not total, clawback of revenue. And of course, as of now, vaccines are rolling out across Europe. So we'll be asking today, what is the future of ophthalmology for 2021 and beyond? What are the challenges and where are the opportunities? With me today, I am delighted that we have an expert panel with decades of experience between them to help address those questions. Peter Bijloos has worked in healthcare industries across Europe throughout his career. He is the CEO of Optegra, a UK-based international eye care provider with more than 25 hospitals across the UK and East Europe. He was trained as a medical doctor in Leuven, Belgium, and started his career in international roles in public medical device companies before he did his first private equity turnaround of the Handicare Group in Norway for Nordic Capital. He was also a partner in the healthcare arm of private equity firm GIMF and holds a couple of board positions in healthcare services companies. Good afternoon, Peter. It is a pleasure to chat with you again.
Thank you, David.
Buy and build specialist Dr. Volker Wendel is the CEO of ophthalmology network Synoptis. Asked why he founded the company, Volker jokes that nobody would give him the job he wanted running an innovative ophtha group, so he built one together with Telemos Capital. Things are going very well. In just 2.5 years, and almost under the radar from the off, he and his partners have been quietly expanding the business, growing to span 160 locations in Germany and Switzerland. Volker was formerly CFO of Artemis Augenkliniken, and for 8 years was CFO at Swiss hospital group Emmaus. Volker, it's a couple of years since we last spoke at length. It's great to see how well Synoptis is doing. Welcome to the chat today.
Thank you very much, David.
And our third and final panelist is Tobias Kostas. Tobias is a partner at LEK Consulting and heads the Munich office. He's a member of LEK's European Regional Management Committee and a senior member of the European Healthcare Practice. Focusing primarily on healthcare services and medtech, Tobias has particular expertise in the outpatient market, including ophthalmology chains, and has advised leading players in the medical device arena across a broad set of geographies and therapeutic areas. Tobias, welcome.
Thank you.
I'm David Farber, I'm your moderator today. I am the editor at HBI. I have oversight of our Deals and Insights news service and the written component of our business intelligence. And so, on to the questions. Ophthalmology covers a wide spectrum of work: cataracts, LASIK, multifocal lenses, AMD injections. Peter and Volker, I'm interested in you briefly explaining the focus of your companies to get some context, what your bread and butter work is and why. Peter, can you very quickly give us a synopsis of what you do?
Yes, of course, David. Mainly high volume pathway work, cataracts, vision correction, private cataracts, refractive procedures, as well as AMD injections. Or split is probably about 50-50, self-pay versus public. That's about it.
Fantastic. And Volker, same question if I may.
Well, we're in network active in Germany and Switzerland so far, with more than 160 locations. And yeah, of course, we're doing a lot of cataracts, around 40,000 a year, around 60,000 intravitreal injections, a lot of consultations. So conservative business is another piece, important piece too. So it's around 700,000 consultations a year. And then we have the refractive business, of course, and maybe a little unique situation. We have two hospitals that are real hospitals, but eye care hospitals. So, and in these facilities with around 20 beds, we do basically all kinds of surgeries, like a university clinic almost, one can say. So cornea transplants, retina surgeries, lid surgeries, and so on. So we are fully fledged ophthalmic service provider.
Fantastic, thank you. Let's start with a question that we can't avoid. So I'm sure that we all want to talk more about going forward into this new COVID-aware environment rather than majoring on how we got to where we are. But it's impossible to ignore what we've just gone through and what we're still going through. So let's start with a wide question. Tell me about some of the challenges and some of the opportunities perhaps which COVID has presented. And I appreciate that this will vary from region to region. Peter, how have you found the last year, and what are you taking from it? Big question, I know.
Well, exciting and challenging year. I'd like to start with the opportunities. I felt honestly that there were more opportunities than challenges. It's very difficult to compare markets. Or East European markets are very different from the UK. But I would like to pick two examples. The first example is related to the Czech market. Czech market is outsourcing the public care for 80%. So probably the 100,000 cataracts are for 80% outsourced. We're doing about 25 to 30,000 cataracts in Czech. We're basically the leader, and it created great opportunities for us to prove to the community, that we can do high volume cataract surgery in a very safe and effective environment. So we were, much quicker than most of the public or small providers, to get the PPEs, to get the social distancing and get the pathways up and running to deal with the waiting list and with the government demand. So I do think that's, one opportunity is, having high focus volume producers, with high clinical outcomes, that are going to be able to do some of the public, cataract markets. Czech is a pioneer in that, outsourcing that. They publish all data, all complications, national list. And there you see that from an NPS and PROM perspective, of course, private providers, have absolutely a place, and that we can lead with that. Second example I would pick up is related to UK and opportunity, a very different market, I'm focusing there on the private market, self-pay. And take an example there is that we have learned through COVID, that we were allowed by the Royal College, to do informed consent through video. And so we have started to do virtual pathways with e-clinics. Optometrists basically are, picking up the phone with the consumer, and going to do a 20 to 25 minutes, discussion, about their, basically requests or medical needs or, consumer needs. We've done about 8,000 virtual clinics, over the last 6 months, and it has proven to be a pathway that we would never let go anymore. So in UK, every single self-pay patient, is going forward, with or without a COVID or pandemic, we're going to do with a virtual consultation, because it makes our clinics so much more productive, and deliverable. Yeah, so these are two examples I say about the opportunities we've taken. One of the challenges has been in the different jurisdictions. We're not talking about Poland, but we had similar, indications there or opportunities there. Is the shutdown opening up? Relaxing. The measures keeps on constantly changing. And so you need to adapt, week by week, month by month, toward the environment. And what's happening often is that, when Boris is announcing a lockdown, you have the elderly patients, not coming the next week, into, your waiting rooms, And so you see a high degree of mix and emotions, as a result of, let's say, a pretty volatile impact, of government decisions, dealing with the COVID situation.
Sure, and you've talked publicly about this before, but the financial hit that you took, that your company took as a result of COVID, by and large, there was then pent-up demand, which you were able to tap into. I believe that you'll tell us that you were able to claw back the money that you lost.
I think we closed 2020 in growth, in 3 areas, we saw absolutely double-digit growth, even in Czech and Poland, during COVID.
Hmm. And that presumably is not something that when you looked at the books in March and you looked at the pandemic that was breaking, you wouldn't have expected that. I assume that was very welcome news.
Of course not. Of course not.
Yeah.
We had a worst case scenario, and shareholder wasn't very happy with that. Yeah.
Sure. Volker, same question really. Challenges and opportunities created by COVID. What have you had to deal with? What have you taken from it going forwards?
Yeah, of course, many things are similar to what Peter experienced, so I don't have to repeat it.
Sure.
To begin with the result, maybe for us, 2020 was as well very successful year, a year with growth. We were able to really catch up all the surgeries we missed of course, in March and April, then in summer and autumn. So yeah, we're happy with the result. Of course, it would have been even better without COVID, but nevertheless, especially the intravitreal injections showed to be very stable because, I mean, the patient has to get the injections on a regular basis. So we had almost no hit there. We had a certain postponement of cataracts from, as I said, March, April into summer. And of course, regarding consultations, we saw a certain reduction, especially people not showing up. Yeah. And accordingly, we adopted our processes, just calling the patients before, asking, do you intend to come? If not, what is your concern? Telling them about the measures we of course took. So we were able to stabilize that as well. And what we have seen that in the refractive business, there was a special growth, both for the pure refractive business and the co-payments. Yeah, maybe due to the fact that people were not able to spend the holidays where they planned to and had additional money to spend for healthcare. We don't exactly know, but we really saw a rising demand there.
And people perhaps, because they were thinking about it more, they were locked up more, they had a slightly higher amount of money to spend, and they were willing to pay extra. Is that effectively what we're saying?
Yes, exactly. Especially for premium lenses, femtophaco, or ICL treatments. Yeah, we have seen a steep increase even during COVID times.
Interesting, and an increase in copay as well. Fantastic. Tobias, do you have anything that you want to add to that from a European perspective? How have you seen the market struggle and recover over the course of the last 12 months?
Yeah, no, I think the two or various relations that Peter and Volker described from Eastern Europe via Germany to UK, I think that is quite representative to what we've seen all across most European markets. I think there were some local variations to the theme, but very stable AMD or IVOM business, as it's a chronic-like disease, which very important in the German market, close to 30% of the revenues for an average provider. Then on the diagnostics and consultation side, which is another 30% of the total German market, and in other regions as well, you've seen some cancellations, people not coming in, often many clinics not opening up. So I think that sort of dried up also the pipeline of some surgery centers. But then cataract, I think, yes, impact on the volume side. During the lockdown, obviously, some clinics were not even allowed to open up, which we can pick up probably in a later course of the discussion. And then, on refractive, steep increase also, as you can see from some of the public reported numbers from some of the larger international players. There was more disposable income to be spent on treatments that are considered private pay. Absolutely.
Yeah, thank you. And just picking up on what you said there. So, and I appreciate this is jurisdiction dependent, but we read in some jurisdictions about lengthening, say, cataract lines or waiting lists, etc. And that leads into a question about outsourcing potentially. How is the market changing? Do we expect to see more government outsourcing? I'm sure everybody would have a view on whether they'd like to see it. Peter, any thoughts on whether we're likely to see any change in the extent to which we get outsourcing? I know that you're in various jurisdictions with different approaches.
Yeah, I haven't spoken about the Polish market. There's a limited amount of outsourcing. There has been a lot of transborder, cataract surgery in the past. They cut that back with reimbursement changes. So I guess it's going to take some time, before there's a lot of more pressure. But in the UK, if you talk about outsourcing cataracts, clearly the trend has been ongoing. Out of the 500,000-600,000 cataracts in the UK, there were barely any of those outsourced 10 years ago. Currently, we're probably at a 50,000-100,000, number of cataracts outsourced, and we expect that goes towards 250,000, depending on the next 18-24 months, what is going to be the pent-up demand, what's going to be the waiting list, and how is the framework agreement and NHS England will deal with that. But obviously, I think as a role of a, let's say, independent provider, doing, cataracts at tariff, as long as we can do high volume, 24 on the list, deliver excellent clinical outcomes, with great prompts and NPS scores, and those two last, KPIs will be critical for governments, then why wouldn't the government outsource, that, to keep the costs, reasonable for the taxpayer?
Sure. Generally, the answer to that in the UK is for political reasons, though ophthalmology stands apart, I think, from some of the other criticisms that any breach of the sacred NHS might otherwise engender. Any helpful government regulations? You touched on 5 minutes ago on the shift towards online consultation, e-clinics, virtual consent, etc. I guess that feeds into how the market's changing in government support as well. That's to be encouraged, and presumably that's a change that's potentially here to stay now that everybody has appreciated the benefits of it.
Question for me, David?
Yeah, do you want to finish up on that, and then we'll bring Tobias and Volker?
Yeah, we've seen in other jurisdictions like the Benelux, as well Belgium as Netherlands, where local insurances or the government has started, let's say, publicly reimbursing, e-clinics, So that's definitely, a trend that hopefully will stay, long term. I think we also have to move from fee for service to pay for outcome. And we see also a number of regulators, looking at, complication rates, your training activities, your second intervention. And so they're more and more going to look at, the longer story, and look at pay for outcome, and that's definitely going to be a trend long term, where if you provide the prompts and the NPS scores, you can really, provide a lot of value.
Volker, and forgive me for traveling along the line of participants in one order. I'll mix it up a bit for the next question. Volker, your comments, please, on how the market is changing and whether you expect to see more government outsourcing, for example.
I mean, the question is a very British question.
Yes, indeed. Yeah.
Because, for example, in Germany or in Switzerland, we don't know anything, such a thing as government insourcing. Basically all surgeries are outsourced, a certain amount to hospitals. Some of them are public hospitals that not comparable to the NHS system, so independent hospitals that have competition as well. So we know nothing else than outsourcing from this perspective.
Sure.
And but what we clearly see is a certain shift, I think, to maybe specialized ophthalmology services, and maybe bigger entities, bigger groups, because in Germany and as well in Switzerland, we used to have a very fragmented market with small practices, maybe one surgeon working as consultant, two looking at his own patients, and then doing the 300 cataracts whatsoever a year out of the patients he saw himself. And this is something that is changing right now due to more pressure on the tariffs. So we have a trend to more to bigger centers, to higher volume surgeons. I mean, that's a trend basically in both Switzerland and Germany, I would say. So coming from the other end somehow.
Sure. Tobias, anything to add on this?
Yeah, no, maybe just to chip in there, I think also picking up what Volk and Peter said, I think providing proof of superior clinical outcome, more patient satisfaction or higher patient satisfaction, I think is something that is not just important for the refractive space, but also gives you much more credibility when you are in direct negotiations with the payers. And I think ophthalmology in Germany specifically is there really on the forefront in terms of penetration of direct contracts between the public insurance system and the private providers, and has helped in the past to really pull a lot of volume or the large bulk of the volume these days out of the inpatient sector into the specialist outpatient clinics.
Fantastic. Questions are coming in thick and fast, which I'm delighted about. So thank you to the audience for that. And I was going to naturally go into M&A in any event. There's a question from the CEO of Opti Eye Care chain in Brazil. How do you see the M&A activities in the ophtha segment? And I guess I'd add to that, are we likely to see more consolidation? What are the prospects going forward? Any effect on pricing of what's happened over the course of the last 12 months or so? Volker, you buy quite a lot. You've been expanding rapidly. What's your feeling on M&A?
Well, you know, David, 2020 was the most successful year for us regarding M&A. So we signed a lot of deals. I think it's maybe due to the fact that, I mean, we were able to execute deals even during the lockdown on the one hand, and on the other hand, the potential sellers are more willing to sell maybe than some years ago, because the crisis made it obvious to everybody that I think long time there was a thinking the only way is up, which is maybe true, but not always. So thinking about the right time for searching a partner, for joining a network or a group. And I think COVID in a way, caused a mental change there. So we see a lot of opportunities. Of course, we try to realize the ones that we really consider as being attractive. So it's for us, it's a stable environment with a slight increase. So we are quite happy with the situation.
And let me just jump in with a question from anonymous attendee who asks, and this is a question specifically to you, Volker. Do you see further opportunities to consolidate the German ophthalmology market? What motivates practice owners to sell to Synoptis and not Artemis or OSG? Artemis and Oberschara, I think, have got around maybe 9-10% of the market in Germany, I guess. What's the selling pitch, I guess, is the question from the audience member.
That's a good question that he would have to ask the sellers at the end. I mean, I think it's different preferences. So what we offer is really a partnership approach. We want the doctors to keep involved, to maintain a certain amount of shares, to play a leading role. And I think for some of them, that is a very attractive situation, because it enables them to somehow realize some of the value they created on the one hand, but just keep on going and running the business with the partner on their side and develop the business, grow the business. So I think that's appealing for many of them. There might be others that are basically just want to sell as soon as possible and go to, I don't know, the Bahamas or wherever one can go these days. And maybe for them, our concept is not the most appealing one. So I think it's not about better or worse. It's about the preferences of the respective seller and the different concepts we see between, for example, us and other groups you just mentioned.
Tobias, I would have expected a blip. I would have expected some of the negotiations at the start of, Q1 or heading into Q2 to have been put back to Q3, Q4, for there to have been a delay in these processes. Any sort of pan-European take on whether there was a knock-on effect from COVID or whether it was business as usual?
I think in terms of timing, there obviously has been some delays in some of the processes, as it's true for some of the larger M&A deals as well. But I think the effect that Volker described, that people are rethinking what they're currently doing and whether there is a better life for them as a standalone player, I think that has outweighed this delay due to COVID, and actually accelerated some of the thinking. I think we've seen actually single practices, owner operated, that in January thankfully rejected offers that suddenly came back in April, May to potential buyers, and wanted to start discussing handover again.
Pricing trends going forward over the next 12 months, any significant changes to what people have been paying, do you think?
I think Volker probably has much more real life data points on that front. And I think it depends very on the situation. What is the target? Is there strategic value for a buyer? I mean, we obviously now have three large buyers in the German market. So that obviously to some extent drives up valuations. But I think the list is still long, and smaller sites can still be picked up at low single-digit multiples.
Interesting. And what you were saying there about the value of acquiring practices, and Peter, if I can put this to you, we've had another question in the chat, and it's an interesting question. What do you think about when acquiring practices? What is the biggest value you're creating? So what are you after, basically? Is it the branding? Is it advertising? Is it getting new volumes? Is it significant cost savings? And if cost savings, what is the magnitude you can realize on things like IOLs, consumables? Now, it's probably a sliding scale of all of those things, but are you able to say what are the most attractive qualities when you're looking at an asset, and what would be top of your shopping list?
It depends a little bit. It's a question underneath there. Refractive versus public. I'm trying to also answer the previous question on consolidation.
Sure.
If you look at either public cataract or AMD market, it's all about having productivity, and clinical outcomes, and you need scale for that. You need digital pathways, procurement. You need to have the critical skill to do that, and so that's definitely driving consolidation. That's also driving the value, of the acquisition. So it's your material cost, but it's also your data collection, building your algorithms, so who's going to potentially create complications or not. That's from a public perspective. If you look from a self-pay perspective, it's a B2C market. And that requires different skills. And for these skills, you need to have digital pathways, understanding your SOE agents, your PPCs, your social media. And of course, whether you do that for one practice or you do that for 25 practices, your B2C market is very national, but you can copy and paste that across platform. And so I think that's the same value creation. So it depends. If you do an acquisition for public cataract or public AMD provider, then it's a matter of, how can you organize your pathway, your procurement, your data, so you can cut costs, and have greater efficiency. If you talk about self-pay, it's about how you can approach your B2C market, and how you can create greater efficiencies there.
Sure.
I don't know if that answers the questions, but I'm not going to give specific percentages, but you need to do all of these, of course, to make value in an acquisition.
Sure, it's a balancing exercise. Does anybody else, Volker, Tobias, either of you want to come in on that, or shall I press ahead?
So maybe just one sentence from my side, sorry. I think the top line is more important than cost savings. Yeah. So of course you can save something in procurement, but much more important is the the top line, so how you organize your practice, your clinics, beginning with the opening hours and the treatment times and the service offerings you provide there. And I think that's where we can really generate value. And of course, the second thing is from a risk perspective, for us as a provider that has both consultations and surgeries, acquiring a conservative practice means as well securing your patient flows and at the end your cash flows too. So that is another element, stabilizing your P&L. And that's something, by the way, that helped us as well to go through COVID relatively good, because with our own practices we were able to keep them running, whereas some of the independent standalone practices just shut down for a while, and then of course did not send any referrals. So for us, a certain mix between external and internal referrals is important too.
Tobias, you wanted to jump in there.
Thanks, Andy. I think it's a very important point that Peter made. It's essentially you have three market segments, right? One is sort of the diagnostics, securing the referral flow for the medical treatments such as wet AMD treatments and cataracts and other medical induced treatments. I mean, that's sort of one diagnostic-led service, and then you have obviously surgery centers which rely on those own referrals or referral practices, and that is obviously more or less fully paid, and you can create a brand and start to upsell patients with premium services to some extent in Germany and in Switzerland. Spain is also a market where you can do that well. And then there is the refractive segment, which Peter mentioned, where you need to treat the patient as a consumer, and you need to engage with them on all channels and essentially win the patient, win the consumer, and not depend on referral. It's your own flow, and you need to create a brand, and it's less around really optimizing the volume there, but rather creating a true journey for the patient that he can enjoy as a consumer.
That's interesting, and just this links into a question that we've been asked by audience member Philip. Forgive me, I don't have a company. Just looking at the various ways in which you can look at ophthalmology and break it down. What's the view on trends between mandatory treatments like cataract and IVOM compared to refractive surgery? And are medical players like Synoptis well positioned for the private pay market? The tabloid journalist in me, and forgive me, I used to be one, would say what's hot and what's not. But trends when you're looking at the different subsectors within ophthalmology, would anybody like to comment on where we're headed? Peter, you're smiling, so I'm going to come to you first, if I may.
I think we're going to all go into more specialization. I think more focus, and so it's very difficult to try to do everything very good. And so every company, in every market, you need to select a number of things you want to do really, really well, and go for that. Specific answering trends, refractive more attractive, than public. It's really a difficult question to ask. It depends on where you are as a company, and what are your tools that you're having in your bag. The market will also be, it's sometimes, also more hybrid, where the copay comes in, where you have, a mix versus, a patient, and a consumer. And the second thing I would say is that, if you have a high waiting list, in a market without copay, like in the UK, of course, the self-pay will benefit from them,
Sure.
So.
And I guess there could be, I mean, the drivers will be changing. I mean, the standard drivers, aging population, etc., will always be there. But What about things like new technology, STEM technology for glaucoma, or new drug treatments for injections, or maybe it's a step too far, but there are robotics being pioneered in Germany for surgeries, for example. Is there anything that you're particularly keeping your eye on in the sort of new technology and development front?
I think for us, it's more the digital platform and that
Sure.
technology, and understanding, what is going to happen with the patient in that vertical integrated pathway.
I think
That's where
We try to be at the forefront of the developments, and we have an innovation hub within our network where we explore new products or solutions. But I think it takes a lot of time until the development really has a breakthrough. So if you look, for example, at AMD treatments, there has been a lot of talking for many years about new drugs that might replace the other ones with less injections or just to be taken orally. And so far, it did not turn out to really become a breakthrough. But nevertheless, it's important for us to see what is feasible. I mean, laser treatments against dry AMD, it's another thing that is been discussed for many years, but so far no real breakthrough. But you never know. I mean, things can change easily. I think 15 years ago, nobody would have imagined how important the intravitreal injections would be today. So I think you always have to keep your eyes open and have a look at all the developments.
Sure.
I agree. I think there are risks and opportunities in all segments. I think on just closing up with the AMD treatments into IVOM, there you also have potential drugs in the pipeline to treat dry AMD with injections, so that might suddenly almost double the market. Then I think on cataract, obviously, multifocal IOLs have penetrated the market over the last decades. Trifocal lenses after bifocal lenses, etc. And now suddenly, even after we've seen lots of innovation in the laser treatments for refractive surgery, where essentially it opened up a new market when Zeiss launched their SMILE procedure, and we now see a lot of clear lens exchange treatments replacing sort of lower cost laser treatments, and then I think one of the biggest innovations in the refractive space was the ICL from STAAR, which opened up a new high-end treatment. And now you see the next generation of ICLs being launched for presbyopia treatments, which will open up the treatment opportunity with ICLs to a whole new patient group. So I think lots of needs and lots of treatments to come.
I can give, if you want, an example of that, David. We used to do mainly refractive surgery in Poland. Self-pay is 85% of our business. And we typically see 95% of the patients are younger than 45, 50 years old. Since we have been, able to have the capability to do presbyond, the Zeiss laser procedure for presbyopia, which you can do between 50 and 60 years old, we basically can tap into, a 30% larger market, with a higher spendable income, thanks to an innovation of Zeiss.
Sure. That's really interesting. Thanks, gents. If we pull all of the elements together that we've been touching on, so the possibility of more outsourcing in some markets, maybe a shift towards additional self-pay, additional consolidation, you throw in COVID into the mix, you're getting a picture of a different kind of ideal clinic in the future. This is a clinic that perhaps is, and I'm going to pinch a phrase that I know that you've used in the past, Tobias, so apologies, I'm stealing your phrase, a monoculture surgery center. So this is going to be doing very high volumes, but that's not necessarily something that your well-paid, well-respected clinicians have bought into. So how important is it to bring your senior staff or all of your staff with you? And how do you do it? Because they didn't necessarily sign up for this brave new future that's being created, that the payers will certainly want, because it's best for the patients, they will say, and probably you will say, and it's best for them because they get high throughput. Peter, you're smiling again. It's always a mistake to smile because it means I'm going to come to you first because you're thinking of an answer. What would you say to that?
Well, I'll look at the glass half full. It doesn't have to be poorly paid. If you do 25 cataracts on a day, in a focused environment, that is probably a better pay than doing 2 private patients. Secondly, work-life balance. You can do 3 days surgery, high volume, and do 2 days of scientific work or other activities. Scientific data collection. You can do a lot more science, if you do a high volume specialized work. So I would see it from a positive perspective. It will require a specific DNA for surgeons, to be willing to do 3 days of high volume surgery work. But those that are keen to do that, will enjoy it and have greater outcomes, and better service.
And how do the clinicians feel about this change? You've been talking to them. Are they accepting? When you pitch it in that way, do they buy into the concept?
There's a number of clinicians that are really keen on that, and there are probably a number of clinicians that are less keen on that.
Okay.
Yeah.
And I guess I should say, what do you do when they're less keen? Forgive me for asking a provocative question, but how do you deal with that?
Well, there's first line ophthalmology. There's complex cases. There are public hospitals. That are not organized like a focus factory. And where you do lots of complex therapies. Or where you do first line. In the community. So I think the clinicians, definitely there will be, it will be important, to understand, how to motivate, attract your clinicians, but, it will not suit everybody, every time.
Sure. Volker, if I understand our previous conversations about Switzerland, I don't think there's a lot of high volume surgeons in Switzerland. What's your take on this particular issue?
I mean, there are a few ones, and some of them are on board already. But in general, yes, it's true that historically most surgeons used to work as consultants too and have a look at their own patients and then basically treat the own patients. And I think this is changing, as I said before, but I think what you will always have is a certain mix between surgeries and consultations, even for a surgeon. Because I think, yes, there are surgeons that like to do 25 cataracts a day, but not 5 days a week. So for them, it's important to have a personal contact to their patients, especially, of course, private patients, but not only complex cases, it's another thing. And they want to have a certain balance. Yeah, and I think this is something that is helpful from a marketing perspective too, because for some people it makes a difference. Some people are more cautious. They really want to see the surgeon before doing the surgery. Others don't really care, say, well, I trust the institution and that there will be a good surgeon. So I think it's people's business, and so you have to reflect the individual preferences, both of the patients and of the physicians, and at the end you will end up with a certain mix. But in general, I agree that there is a trend towards more high volume surgeries for sure.
I think the interesting opportunity for larger chains is that you have to offer a breadth of roles to your clinicians, to your nurses, and that you can cater according to their needs. I think that's a very important message and a very important benefit of these larger platforms compared to the individual sites or smaller chains where you don't have the flexibility to shape some of these roles to the individuals. And I think as Peter said, they're individuals, and some don't even like to talk to patients. Others want to spend 4 days a week with the patients, and not when he's under anesthesia on the table, but when he's actually in a room and able to talk.
Sure. And a supplemental question, Tobias, I'll come to you first if I may. What is the best place to provide ophthalmic services? Do dedicated clinics have an advantage over the large hospital? I think in Germany, for example, most of the big hospital groups, I think, do ophthalmology in-house. Clinic or hospital, discuss. What do you think is where's the balance struck between the two?
I think the payer obviously prefers an outpatient setting for cost reasons, and we've seen so much specialized service providers that even the clinical outcome has become better in these sites, as they're just also have higher volumes and track closely the outcome. You still obviously have some comorbid patients which need to be treated in a hospital, which not need to be in the bed after surgery. But I think the future is for most of the procedures, most of the surgeries in the outpatient setting, and especially during COVID, many patients tried to avoid large institutions where there were also other patients treated, especially COVID patients treated, and they shifted themselves to the outpatient center and tried to get treated in a safer specialist environment.
Sure. Peter, you're a clinic fan, aren't you?
It depends. It depends what your need is. If you need a cornea transplantation, maybe you shouldn't go to a daycare center, but go to a complex center that is doing 200 on a list, on an annual basis. So it really depends on what is the indication. But if you're talking about cataract surgery, for example, again, or refractive surgery, it's easier for a patient to go to a daycare site, have a 200-yard walk, a 15-minute turnaround, and go home, than going into a very large, 2,000-bed general hospital.
Sure. Volker?
Yeah, I just can confirm what Tobias and Peter said, and maybe just add one thing. We have in our network two, let's say, hybrids with these eye hospitals. And here we have seen a trend coming from the big hospitals, because normally a hospital to have an ophthalmic department has a quite remarkable size. And in most cases, there are big community hospitals or even university hospitals. And there we have seen a clear shift towards our smaller hospitals, even for like cornea transplants and other, let's say, severe surgeries due to COVID, in general. And maybe as well in the long term due to a higher service quality that you can provide. I think that's in any case very important to be successful, not only for the self-payers, not only for the co-payers, as well for the public patients. They expect a certain level of care and treatment and patient journey, as we said today. And I think this is something that smaller units can offer much better than the big hospitals that have a totally different setting, which is not really compatible with this kind of treatments in patients.
Sure. And Volker, while you have the floor, another question specifically for you, and it's a Germany specific one, so we won't labor the point on this, but briefly, because it's nice to address all the questions as they come in. How would you assess the risk of further regulatory restrictions / changes in Germany, similar to the ones imposed through the TSVG for dentistry? Are we going to see further regulatory restrictions? I mean, I guess in dentistry, if you want to open a dentist, you have to own a hospital, etc.
That's true for ophthalmology as well, but is restricted in dentistry how many centers you may buy and so on. So that's not the case in ophthalmology yet, and we don't really think that this will change. Of course, talking about politics is always guessing somehow. But if we look at the current government and the current health minister, I think they have a lot of other issues right now than to think about a further increase of regulations. So we expect it to be stable for the next years in Germany. And in Switzerland, you have, it's a really German question, as you said, David. In Switzerland, they don't even know what we mean when we say we need a hospital in Germany to buy a clinic. They look at us and say, "Oh, really?" So, but even the Germans have other issues now than increasing regulations, I think.
Sure. If we open it up to ask if there's any restrictions on the horizon in any of the jurisdictions that you're familiar with, any problems that we can see over the next sort of 12, 24 months, gents?
I'd say in Germany, just to add to Volker's feedback, there actually has been an expert opinion been completed for the Ministry of Health on that topic, which has been published towards the end of last year, and that actually considers the restriction for dentists, for example, most likely unconstitutional. So I think the MOH is actually aware and has been aware for decades now that if you want to cut delivery costs in the long term in the outpatient sector, we will need to see consolidation of the more than 100,000 outpatient clinics in Germany, and that I think is an important feature, and it also if we don't consolidate the sector, we'll just end up with massive labor issues because there will just not be enough medical staff to treat all these patients in a very inefficient, decentralized structure. Sure.
Thank you for that. We've had what may be a controversial question. I hope not. I'm going to ask it, but nobody has to answer it because I don't want to get into any trade secrets. But the question is this: what would be, from your perspective, a sustainable EBITDA margin? Comparing OSG, Artemis, and Synoptis, there are some differences varying from 20 to 35%. Is that linked to HQ setups, different share in business activities, clinics, practices, cataracts, IVOM, refractive share? Now, you can't just have a single two-digit answer to this. Well, the answer is X. But would anybody, Volker, would you like to address what a reasonable EBITDA margin might be, or what you look for when buying a practice, perhaps, and adding it to your business?
So I will not comment in detail about EBITDA margins, of course.
Of course not. No.
I mean, when we look at targets, I mean, you can see it from both ways. Is a high margin good or bad? Question is, can you keep it as high as it is, if it's high, or if it's relatively low, are there ways to improve? So we always try to look at not only at the current situation of a potential target, but as well at the business plan that we consider as realistic for this specific target. And then in some cases, a lower margin might even be interesting because you say there's some space for improvement. But what we try to do in general is to really keep our overhead costs relatively low, because we don't really believe very much in centralization. I mean, for some topics, it's important for procurement, but even there you don't need many people. You just need somebody who negotiates the contracts. But we don't really believe in this administrative functions to be centralized because, what you always generate is costs. The question is always, do you generate added value for the clinics? And this is not always the case. So we really to try to keep it as low as possible regarding the administrative costs and overhead costs. And I think in general, the best thing to increase the margin is increase your throughput, your utilization of the facility, and of course some upselling, some premium business, co-payment business can help too. But the most elementary thing is throughput, its efficiency, as Peter as well mentioned, and that's the things that's the levers we are working with.
Peter, by pure coincidence, as I got to the tricky question about EBITDA margins, you disconnected, so welcome back. The question was largely, and I framed it as being an impossible question to answer really, because you can't just pull a figure out of the air, but was about what a sustainable EBITDA margin might be comparing OSG, Artemis, and Synoptis. Do you have any general comments in the wake of what Volker was saying about EBITDA?
I agree with Volker is that, maybe I'm not going to, quote numbers, but productivity, utilization, and clinical outcomes, those are the key drivers. Look at those if you want to invest in a business. And then 2 side comments: decentralization, absolutely yes. Cut overhead, as much as you can. And secondly, because you need to innovate, and that happens, from a pilot perspective, decentralized. And secondly, skin in the game by clinicians. It's so critical, and I agree also with Volker, it's so critical to have the clinicians on board to drive these pathways. And if you have those 5 components on board, I think double-digit EBITDA any time of the day is you can do without a problem. How much more? That depends on jurisdiction, the tariff, and lots more details.
Sure. We are running out of time, but a quick answer perhaps. I think we've touched on this already to a degree, maybe not specifically called it out. Can you comment at all? I'm just reading a question. Comment at all on the level of demand you're seeing in the markets at the moment, and whether COVID is still having an impact on patient willingness to get procedures done? And if so, when would you expect volumes to normalize? Volker.
Of course, we see an impact now. I think there's a strong correlation between lockdown, especially when the shops are closed, the general shops are closed, and the especially number of consultations. So we see a certain decline there. Since we have waiting lists in most of our entities, it does not really affect the surgery volumes as of now. But of course, the longer the lockdown lasts, the more likely it is. So of course, thinking about developments with COVID, it's again guessing. But what we expect is to see an impact for the first quarter, of course, for the second quarter too, and that then hopefully when the vaccination is really increasing, hopefully having a relatively undisturbed third and fourth quarter, and hopefully then 2022. So that's what we expect so far. I think there is a certain way to stabilize it. I mentioned that already. If you call the patients, you can reduce the number of cancellations. But if you have less appointments from the very beginning, of course, there's not that much you can do for that, for instance, at least,
Sure. Tobias, any thoughts in a fairly brief period?
No, I think I'm fully in line with what Volker said. Cancellations, no-shows are an issue these days again, but I think specifically patients with the chronic like AMD treatments, they continue to show up and has barely seen any declines throughout the past lockdowns, similar to dialysis patients, which is ran stable. I think we'll see an increase as the numbers are going down now. The pandemic numbers, we'll see a strong catch up again on cataract. That's my personal expectation.
Sure. And Peter, I think we had the German market pegged at about 3.6 billion euros last year, growing at about 5%. I think Czechia was growing at about 5%. Although in Germany, cataract treatment was growing at about 2 and eye injections between sort of 6 and 8. So it varies depending on which bit you look at. But market growth over the course of the next 12 months, or to go back to the original question, volumes normalizing, how do you see it over the next year or so?
I agree with Volker and Tobias. It's going to be a bumpy ride in the next 6 months, And it depends really from segment to segment. Is it self-pay or is it public? Is it elderly patients or is it younger, consumers? Or is it AMD or other, diseases? So I think different segments, different trends. Clearly, that's, we hope and expect that will stabilize post-summer with a lot of pent-up demand. That leaving aside, high single-digit growth numbers, definitely in the market, for the segments that we have been talking about, of course. And then we have the high waiting list, and the pent-up demand for the next 12 to 18 months to deal with. Fantastic. And on top of that, a lot of hospitals that cannot cope with the demand of the daycare surgery, and so potentially a shift from volumes.
Great. Surprisingly, because the time has flown by, it's now 3 o'clock. Our time is up. I'd like to thank our panelists for a lively discussion. I'd like to thank the audience for its participation. We had some great questions there, so thank you for that. I'm contactable, david@healthcarebusinessinternational.com, if I can be of any assistance going forward. Thank you to the panel. Thank you all for your time. That concludes today's session.
Thank you.
Bye-bye.
Thanks, everybody.